First of all, I'd like to thank all of audience for joining us. I hope you will enjoy the meeting. In this session, I'm going to talk about external validity of Afib ablation trials. We all know perceptions are not realities, but anyway, they are the main drivers of our daily life, our real life. I'm going to show you a video, probably most of you heard about it, but please listen it again and say what you hear.
Laurel, 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 laurel.
This video originally belongs to a vocabulary website, and they thought that this sound is valid as laurel. But in real life, 53% of people were agreed with them. Rest of them were thinking completely different. I assume that this is similar for scientific trials. We all accept one of the important aims of a trial is improving public health. But at that point, you should answer some questions. How are the research results translated to the public health practice? Or in other words, can this trial represent real-life clinical practice? To answer these questions, you should know the external validity of a trial. That means whether causal relationships can be generalized to different measures, persons, settings, and times. Actually, we have two types of validity. The other one is internal validity. Historically, researchers have tended to focus on maximizing internal validity, so design and conduct must keep to a minimum the possibility of bias. In general, validity means how sound your research and method are. Regarding the validity, there are two types of research level, and it remembers me one of the famous fresco of Raphael, School of Athens. In the middle of the painting, you see Plato and Aristotle together. Plato's hand is up. It's pointing to sky. So he was idealist. His student, Aristotle, was thinking different. His hand is pointing the ground, pointing the earth. He was realist. Efficacy studies investigate the benefits and harms of an intervention under highly controlled ideal conditions. So they have higher internal validity, but effectiveness studies examine how well an intervention works under real-world practice. So they have higher external validity. Distinction between efficacy and effectiveness trials is not a dichotomy, it's actually a continuum. Numbers of threats to external validity. Here are three examples: timing, setting, and participant characteristics. Timing, the historic threats means observed effect does not generalize other time periods. Actually, it's mentioned more than 2,000 years ago by a pre-Socratic philosopher Heraclitus, and he said that no man ever steps in the same river twice, for it is not the same river, and he is not the same man. I think Afib trial is a good example for history threat. It was published in 2002, and they included more than 4,000 patients and randomized to either rhythm control strategy or rate control strategy. And some outcomes measured such as death, hospitalizations, and adverse drug effects. And they found that rhythm control no better than rate control. Higher mortality trend, more hospitalizations, and many more adverse effects with rhythm control strategy. So authors concluded that none of the presumed benefits of rhythm control were confirmed in this study. But the question is, does Afib trial represent our today's life? At that time, there was no detailed scoring systems, such as CHAS2 or CHAS-WAS score. There was no NOACs, and now we have more safe and effective catheter ablation technologies and techniques. And recently, East AF Net 4 trial has been published, and they showed that early rhythm control strategy is better than usual care. So we see that a contemporary trial offers a counter-argument to Afib trial. Another threat is participant characteristics. Here is the example. 55 years old lady who referred to Afib ablation asks about the procedures. She'd like to know the success rate or complication rate of the Afib ablation procedure. We know when you compare the women with AF have poorer functional capacity and their AF symptom severity is higher. Afib ablation is a reasonable option for women. Regarding the quality of life, women with AF are known to have worse outcome, and side effect from the antiarrhythmic drugs is high in women with AF. So they have more proarrhythmia and more fatigue with drugs. But women are referred 3 times less frequently for catheter ablation. At the time of referral, they are significantly older and more comorbidities. Large randomized studies of catheter ablation enrolled much fewer women than men, and meta-analysis of outcomes for Afib ablation have described male predominance as high as 90%. And we know that females have lower success rates and a greater number of vascular access complications. So in terms of ablation, women are not equal to men. Therefore, we cannot inform a lady with an average outcome. Another difficult issue in our real life is management atrial fibrillation in patients with heart failure. Another example, 60-year-old male with persistent AF and heart failure referred to our clinic for Afib ablation. 5 years ago, DDD-ICD implanted for primary prevention. His New York Heart Association class is 3, ejection fraction is 20%, and left atrial diameter is a bit larger. Is Afib ablation useful for this patient? I think our patient would be eligible for CASTLE-AF trial. So they included symptomatic atrial fibrillations. Left ventricular ejection fraction is lower or equal to 35. New York Heart Association class is higher or equal to 2. And they selected device patients for detecting atrial fibrillation ablation success rate. And we all know the impressive results of CASTLE-AF trial. Ablation significantly reduced death or hospitalization for worsening heart failure. Ablation produced a relative reduction in primary outcome, nearly a primary outcome of 40%. And also we know that ablation reduced cardiovascular death by 51%. But the question is, who were these patients? I mean, we should focus on those who enrolled to CASTLE-AF trial. Median age was 64, mostly male patients. Median body mass index was 29, and mostly New York Heart Association class 1 or 2 patients, mostly non-ischemic, and the median ejection fraction was 32. So they were young male, non-obese with not severe symptoms, mostly non-ischemic and mildly reduced ejection fraction patients. Many authors criticized the CASTLE-AF trial due to small number of patients, low event rates, unbalanced baseline characteristics, and high rates of loss to follow-up. And recently, a retrospective observational trial has tested the generalizability, the external validity of CASTLE-AF trial. They included nearly 300,000 patients, 7,465 patients treated with ablation, and rest of them treated with medical therapy. Patients were divided into 3 groups based on the trial eligibility. Group 1 was who would be eligible for CASTLE-AF trial. Second, who failed to meet the inclusion criterion. And the third group is who met at least one of the exclusion criteria. And they found that only 7.8% of these patients would have been eligible for CASTLE-AF trial, and 91% failed to meet the trial criteria. And they showed that ablation was associated lower risk of primary outcome in both eligible group and also failed to meet the inclusion criteria. So this trial encouraged us about CASL-AF results. However, the magnitude appears to be more modest than reported in CASL-AF. It was 40%, but in this trial, it was only 18. So we may say that we may not see such impressive results of CASL-AF trial in our real life. When we back to our case is a bit older, and his heart failure is severe. Subgroup analysis of CASL-AF trial showed that there is a trend toward the worst outcome if patient's ejection fraction is lower than 25. So probably ablation will not be useful for our patient. We see the clear paradox of clinical trials. They are the best way to assess whether an intervention works and the worst way to assess who will benefit from it. Another threat to external validity is setting. That means findings do not generalize other environment or situations. I think cryoablation versus RF ablation for the treatment of proximal atrial fibrillation is a good example for setting threat. And remember the Fire and Ice trial results. They showed that in terms of efficacy and safety, cryoablation was non-inferior to RF ablation. Also, cryo was faster, and the radiation was higher in cryo procedures. And remember the Dr. Cook's comment. I think he was pointing the external validity of an intervention, RF ablation, and he said that these were the best RF centers in Europe. These doctors were born to do RF ablation. And recently, a trial asks a question: is cryoablation more reproducible than RF ablation? And they included 860 patients from 6 centers. 467 treated with RF ablation and 393 patients treated with cryoablation. And they classified the centers according to Afib ablation volumes. And they found that cryoablation success rate was similar for all centers, but we cannot say this for RF ablation. If volume is high, RF ablation success rate was high. So these real-world data suggest that cryoablation seems to be less operator dependent and more reproducible than RF in the setting of proximal Afib ablation. I'd like to finish my presentation with a joke. A mathematician, physicist, an astronomer were traveling north by train. They had just crossed the border into Scotland. When the astronomer looked out of the window and saw a single black sheep in the middle of a field, Scots sheep are black, he remarked. No, my friend, replied the physicist, some Scottish sheep are black. At this point, the mathematician looked up from his paper and said, in Scotland, there exists at least one field in which there exists at least one sheep, at least one side of which is black. Yes, we are not mathematician, physicist, or astronomer. We are the doctors. When biology is in the question, when the biology is matter, I think statistics and the mathematics can be misleading in some cases. That's why I believe we as doctors need not only scientific, but also artistic point of view. Thank you.
Which is important for patient selection to any intervention, efficacy or effectiveness trial?
First of all, I should say, in terms of patient selection, shared decision-making is essential. We should share every details of an intervention with our patients and make a decision together. Efficacy trials says us if an intervention works under ideal conditions, but effectiveness trials provide information about real world. So we need a synthesis of them. We need a combination of them. And of course, we should individualize every solutions for every patient.